Finance and Property Committee to order. First item is Pledge of Allegiance. Please rise.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All members of the committee are present. Supervisor Reynolds is remote. Everybody else is here, so welcome. Public comments. Nobody has approached either the clerk or myself relative to public comments, and we have approval of the minutes from the June 12th meeting. What are your wishes? Moved by Supervisor Lemmer to approve. Is there a second? Seconded by Supervisor Poole. Any discussion? If not, all those in favor of approval of the minutes will signify by saying aye.
Aye.
Opposed, no.
Aye.
That motion carries unanimously. 5A1. If without a, can we take that at the end, or is it, how many people are online? Is it? Discussion of health clinic and health plan contract. Should we take that up first or later on the agenda? Molly, I'll defer.
Certainly wait if you'd like to take care of other items.
What are the wishes? We've got the expert here. Let's take it in order. So if somebody would make the motion.
I think we'll discuss A1 prior to 1A and do a portion in open session if that's
Okay.
all right.
All right.
Yeah. So. And he's just going to kind of give us an overview, lay of the land. I know he's given similar presentations. Similar presentations in year past, but with a new committee. Eric, you can introduce yourself.
Sure. Hello, Eric Torberg with USI Insurance Services. I help the administration out with all the employee benefits. So the presentation that I am presenting today have to do with the current state the county has for medical insurance, as well as looking at self-funding versus what you currently have. So we'll just walk through the presentation. If any of you have questions, certainly let me know. So the first slide, just wanted to give you a little bit of an overview as far as what's happening in the health costs, health insurance marketplace. The first thing I cited was a RAND study that looked at the hospital costs for private health plans. So Wisconsin specifically, private employers or public employers in that commercial insurance market pay about 318% of what Medicare pays. So that is the fifth highest in the United States. The average across the whole United States is 254% above Medicare. In discussions with health systems over the past, the reasons they have given, for instance, Marshfield Clinic, Aspirus, they have given the reasoning that the payer mix is higher from a Medicare or Medicaid perspective. So they'll say that 60% of their patient volume is Medicare and Medicaid patients. And Medicare and Medicaid, the health systems say that they do not have any type of margin. They actually lose money on those patients. So then they have to make up for it with the commercial patients, which Marathon County employees in the health plan would be defined as commercial patients. So that's kind of the reasoning as far as why employers pay that much more than what Medicare is. Another study that we're citing is the PricewaterhouseCoopers trend study. And trend is essentially medical inflation. So each year the cost of healthcare goes up a specific percentage. In 2024, it's 7% each year. In 2023, it was 6%, and then 2022 was 5.5%. The reasoning why that continues to increase or creep up every year is actual inflation. So the health systems, the insurance companies, they're using, I feel like I'm very loud. They're saying that the actual inflation is causing the medical inflation to increase. So everything we hear on the news about the inflation, that is contributing to that creeping up to that 7%. So when we look at Marathon County specifically, as far as what your increases have been with Group Health Trust, 2024, they originally came in with a 9% increase. We were able to negotiate that down to 6%. In 2023, they originally came in with a 6%. We were able to negotiate that down to a 2%. 2022, it was originally 2%, and it was able to be negotiated down to a 5% decrease. And then 2021 was a 6.5% increase. So that kind of looks back at the last 4 renewals of the Group Health Trust. The next page, we talk a little bit more detail about the Group Health Trust. So the county, Marathon County, is a member of the Group Health Trust, which is the health insurance for the county. And the way that works, it works similar to a fully insured policy, where at the fall of the year before, Group Health Trust will provide their renewal. So on about Labor Day, we will receive the renewal from Group Health Trust. Okay, now that renewal starts on January 1st of the following year, and it stays the same for that entire year. So it doesn't matter if there's a lot of claims throughout the year, medical claims, prescription drug claims, the premium stays the same, okay? So how the trust works is we use this bucket analogy. So the premium that Marathon County and the employees pay, because the employees do pay a percentage, it goes into that big bucket, which is the trust. So then all the other counties, cities, or school districts that participate in the trust, that goes into the bucket. So when we look at the renewal process for Marathon County, there is a positive and a negative to that. The positive is if you're having a bad year from a claims experience perspective, by being in the trust and everyone putting the money into the bucket, the trust will actually give you a less of a renewal than you may need actuarially. So that is the positive of being in the trust. And they're able to negotiate, as you saw over the last few years. The negative effect is sometimes if you may deserve a lower renewal, there may be a few percentage points built in there because other members of the trust had a less or a greater than average claims year. So that is how the trust works. It is not fully insured. It is actually a self-funded plan. But as far as Marathon County is concerned, the premium looks fully insured for the year. So that is how the current state with the health insurance is. So now, talking about self-funding. So when you have a well-run self-funded plan, there's a bunch of different components to that plan. First component is an independent primary care clinic. Independent meaning not affiliated with a health system. So not affiliated with Marshfield Clinic or Aspirus Health. Okay, so that's the first component of a really well-run self-funded plan. Second component is a robust wellness plan. So the county does have a wellness plan where we incentivize the employees to go to the doctor. If they go to the doctor and do a few other things, they achieve a discount off of their premium. The other thing, plan design. So the plan design, how the plan design is built, and when I say plan design is like your deductibles, your out-of-pockets, your co-insurance, those types of things. How that plan is structured. When you're self-funded, you have a lot more flexibility in how that is structured, and you can support that independent clinic. You can also support the use of lower cost, higher quality providers. In the presentation, we use the example of an MRI. So in Weston, SmartScan is an independent MRI provider that charges $650 per MRI. The health systems charge anywhere from $3,000 to $5,000 per MRI. So that is one thing that when you're self-funded, you have that flexibility to do. Another component is the provider network. And the provider network is the list of providers that the members of the trust can see. So for instance, Aspirus Health would be in the network. Marshfield Clinic would be in the network. So you want to make sure that the network does have good access and provides the best value from a discount perspective. So when I say a discount, I'm talking about percentage off a billed. So when you personally get your explanation of benefits, you'll see, the billed amount and then the discount, and that's because of the network, the provider network. Now these components are the brick and mortar of a self-funded plan. The first one, third-party administrator. So the third-party administrator is the companies that we would hire to process the medical claims. UMR in town here is the largest third-party administrator in the United States for medical benefits. So that is a third-party administrator. All they do is answer the phones, the questions from claims processing. They obviously process the claims, etc. That's what the third-party administrator does. Second component is pharmacy benefits manager. So the pharmacy benefits manager is the go-between between the manufacturer of the drug and the pharmacy. So look at it like a clearinghouse where the plan buys the drugs from. Now the pharmacy benefit managers, this is where things get really gray, because there's a lot of different ways that pharmacy benefit managers have revenue. Okay, so we make sure that the contracts that any of the clients that we work with are very ironclad, so there aren't those hidden revenue streams that you can't see unless you know what you're looking for. And then the third component is stop-loss insurance. So stop-loss insurance is risk protection. When you're self-funded, when you're paying the medical claims or the prescription drug claims, they're actually coming out of a checking account owned by Marathon County. So that's how they get paid. Now, because of that, and because of risk associated with medical claims, $1 million claim is not that uncommon anymore. So what employers do is they purchase stop-loss insurance. And there's two components to the stop-loss. There's a specific that protects each individual per year. So on this, we use examples anywhere from $100,000 to $250,000 per individual per year would have a deductible. And it's not a deductible that the employee or their dependents see. It's only a deductible that's attributed to Marathon County. So their risk would be, for instance, if you chose a $100,000 deductible, the risk to the county would be $100,000 per individual per year. So anything over that for a medical and prescription drug claim, there would be insurance to protect the risk. The other component is aggregate. And in the state of Wisconsin, public sector groups have to purchase aggregate insurance. And that protects the employer from overall costs. So for instance, at the beginning of the year, The claims would be projected out to, say, $10 million. So what you would do is you would buy insurance to ensure that your risk would be no greater than 25% above $10 million. And so if it went to $12.5 million and above, the county would have insurance that reimburses them. So it provides that, we call it sleep at night insurance, so that it protects the risk. Next page talks about some of the pros of self-funding. First is potential cost savings. So how this works is if we project claims for the year to be $10 million and the county has $8 million in claims over that 12-month period, the county would be able to keep that $2 million. So that's where the potential cost savings comes in. With GHT, if your premium is $10 million, that's what you will pay for the year. So the self-funding does provide that potential cost savings. The other things is claims and data transparency. So you get a lot more data when you're self-funded because you are the plan administrator, so you would have access to more data. So by receiving more data, you're able to understanding exactly what's happening as far as risk. With the trust, we don't get a lot of information because it's part of the trust. So that's the reason. Benefit customization, I touched on this a little bit. You're able to structure the plan exactly how you want it. And then I put on their wellness plan. You're able to become much more creative with the wellness plan. Next are the cons of self-funding. Cost uncertainty and budgeting. So I talked about the pros. Well, there is an inverse of that. Because we project the claims, so for instance, if we project the claims at $10 million, you still have risk up to $12,500,000. So there's that $2.5 million risk corridor that the county could be on the hook if something crazy would happen. For instance, when COVID-19 happened with the pandemic, there was a lot of fear that it would drive up claims because people were not going to the doctor. So they weren't being treated in a timely fashion. So those types of risks always exist in self-funded. Second is the reserve amount. When you're self-funded and you're paying the claims out of your own bank account, it is recommended that you have a reserve. So that's like a bank account with approximately 25% of the projected claims. So for instance, if it was $10 million, it'd be $2.5 million that we would want the county to have in a reserve. It doesn't have to be done day one, but it is something, a goal to have. And that the reason you want that reserve is if the claims, if for whatever reason you have a bad claim year, the reserve would help to mitigate that. Risk of large claims, again, risk anytime anything can happen from a large claim perspective. And it does not take much to get a $100,000 claim anymore. So again, that risk. Now the stop loss, which we talked about, does mitigate that risk, but that risk is still out there. Administrative burdens. There are some more administration to a self-funded plan. It's not that the county is cutting a check every month. There's some upfront setup work because you're the plan administrator, so we have to make sure that the plan is set up correctly. Protections of PHI, or protected health information. Because you are the plan administrator, you would have access to protected health information, and there are specific regulations in place that you would have to protect that so that there would be no, no one else would be able to get at that. And then some human resource and finance department work. Again, a separate bank account that the money would be coming out of, and then every week that would happen. So there would have to be some, some accounting work associated with that. Are there any questions? Yes, sir.
Eric, go ahead.
So the stop loss, I mean, that's another insurance carrier, whether it be aggregate or whether it be individual stop loss. And if you have a bad, so you start out based on claims history and you have a premium provided for the stop loss insurance, and you have a bad year, granted, you're going to recover some of that bad year cost initially, or not have to pay part of that claim. But the following year, is it not true that the stop loss carrier is going to raise their premium to cover what they just lost?
They will raise their premium, absolutely. We have negotiated specific contracts with stop loss carriers that they cannot increase their premium by more than 30% year over year. Now, the stop loss premium is not equal to what the premium from GHT. It's about 15% of the total cost of the plan. But that is correct. Obviously, they will increase it. But again, the contracts are such that there are limits on what they can increase.
But 30% increase year one, 30% on top of that year two is now 66% plus in cost increase. I mean, their insurance companies.
Yes.
They're not going to lose money long term. Yeah.
That is a correct assessment.
Eric, I have a question relative to your opening comments, relative to Wisconsin premiums being, your cost being 318% of Medicare. If we went as a state, we're one of 10 states that hasn't done Medicaid expansion, would we lower that to the national average or a savings of, it's 62% less? Has anybody done any actuarial analysis that if Medicaid expansion were to take place in Wisconsin, if that would be more, if the hospitals are more profitable and not shifting the cost, would we see a corresponding reduction in premium?
Yeah, and obviously I don't represent the health system. So a Medicaid expansion would create more Medicaid patients for the health systems, and that would be, they would lose money on that.
Does it also include benefit enhancements and other things, as I recall some of the proposals that have been floated in the past?
No. I mean, the fact of the matter is Medicaid, what health systems will tell you is Medicaid is about 20% of what they need to charge. So they are saying that they are losing a lot of money on Medicaid, or what is called in Wisconsin Badger Care. Medicare, which is for obviously those that are disabled or post 65, that is where they will tell you that they only break even on Medicare. So the health system, the commercial patients, which Marathon County employees are, workers' compensation or through the benefit plan, that's why they charge that much more, because they feel that their Medicare and Medicaid mix is higher than in other states. Now, I mean, that's something that I can't disprove this meeting, but again, that's why Wisconsin is as high as it is.
Scott? There's Supervisor.
Thank you, Chair Robinson. Just a question. Is there a way to get a reliable estimate about what the total cost would be, bottom line, if we went to a self-funded care or the current program? And are there examples from other counties who may have went into a self-funding, how that affected them?
Yeah, so we can actually look at the data through GHT and make projections on what we feel like the county's health insurance will do. And that is something that we do on a regular basis as far as from a budgeting perspective. Lance and Christy and Molly will ask me, what do we think? What do we think the cost increase will be? And that'll happen because the renewal will not come out until, like I said, that Labor Day timeframe. So the self-funded discussion is something that happens prior to the actual renewal. So when we look into the future from a strategy perspective, we'll want to make sure that the self-funded strategy is in line, because that decision will need to be made prior to the receipt of the renewal. So because of the fact that we probably would need to get started in that July timeframe, and again, we won't have the renewal until September.
Bert?
So I understood that part of it, taking up, Mr. Chairman, on the question that you had indicated, the Medicare and Medicaid expansion, from what I understood was there is some component of the society currently that's utilizing the highest cost healthcare systems around, that being the emergency room systems. And in some cases, they have no coverage, no coverage at all. And so I'm just wondering if they were then potentially eligible under the expanded Medicare or Medicaid, would the healthcare systems be less costly? If there's that segment of population that the hospital systems are eating and not having to pay anything. I don't know what the number is, but I think there's a strong component to that.
Yeah, and the Accountable Care Act that was passed a number of years ago, that helped shrink that uninsured number, because certainly health systems were having to write off those that are uninsured because they have an inability to pay because of the costs, which makes sense. So from that perspective, the ACA did more for that type of discussion.
Supervisor Marshall?
Thank you, Mr. Chair. Currently, how many employees take advantage of our offering of health insurance, and how does that convert into the number of insureds? Because typically the plans make more sense the more people you have.
Correct.
To average out the cost, as well as under a self-insured plan, you're only providing or giving insurance for the stop loss portion, whereas there's no markup on the majority of the claims because those are actual costs. So wouldn't it be actually cutting out the middleman for when you do self-insurance? So that was, I guess, a two-part question.
So who you're cutting out is, if you think of self-funded versus insurance. So when you're buying from an insurance company, there's a margin of profit. So when you're paying an insurance company, obviously they're going to project your costs with a % or 2 of profit. That's how that works. So when you're self-funded, the mechanics of who you go to, for instance, Aspirus Health or Marshfield Clinic, you can negotiate, or you can get a provider network that is the most competitive. But it's not lowering the cost instantly by going from self-funded to fully insured. You're cutting out that insurance component, the profit component, those types of things.
And as a follow-up, like what you're looking for is win-win situations. Like you said, if you can send people to the $600 MRI, and that is of zero cost to the employee.
Yep.
And if you want to choose the other MRI, that's up to the employee. However, it's only covered by 80%.
Correct.
What you try to make is those win-win, which this plan allows us the flexibility to do, where under GHT you don't have that. So that's one of the benefits.
Yep.
But as far as number of employees taking advantage and number of insureds.
There's 650 employees on the plan, approximately. It varies every month. And approximately 1,600, what we say is belly buttons. So that would be, dependents, all the dependents as well.
So what lead time do we need, understanding that if we move to self-insurance. It requires organizational capacity, and the fact that we're struggling with implementation of Workday and other things. Do we have, what are the capacity requirements for us to do it this year versus if we had more time to implement systems next year? And part of that's directed at Molly and Christy as well as Eric.
Do you want to start?
Sure. Based on the conversations that I've had with Eric, and he alluded to this fact earlier, if we were going to potentially move to a self-funded model for 2025, a decision would need to be made here in the short term as soon as your July meeting. I mean, it's a pretty fast turnaround. If you're asking specific about bandwidth and our ability to move that quickly, I think if we had that notice, we internally could adapt, but we would need that time. So again, this decision would need to be independent from a GHT renewal that we wouldn't get in time to make these changes. I don't know if that answers the question. Or
Yeah, so, and it's not asking, today isn't about that actual decision, but we would probably look to have a board decision at the July meeting. With that, there would be a lot more data that would be presented in July. So we would get into the actual financial components in that July timeframe and July meeting.
Cody, Supervisor Hart.
Thank you. I was wondering if you could speak a little bit more of the estimated startup cost, because it sounds to me like there's the potential to save money in the long run, but the initial impact could be significant to get everything off the ground. And I don't know who can answer this second part, but what would that be on our budget for the next year? Thank you.
So from a budgeting perspective, the process would be very similar to how it is today, where the increase or decrease, hopefully a lot more decreases than increases, that process would actually happen sooner in the self-funded world. We would be looking at, making these decisions each July and August versus after September. But as far as startup costs, there's no real startup cost outside of having a reserve. And in no ways do you have to have that reserve day one. That is not typically how employers will do that, to have that full amount of the reserve up front. So as far as upfront money, it's not much different than it is today.
The county's been self-insured in the past and fully insured through group health trust, so we have the ability to do either one. So from a financial perspective, we can do it either way. I think the biggest lift will be on the HR side, trying to explain that and working on there. And then we've worked with Eric and his team to come up with the right third-party administrator and stuff. It's going to be work, but yet it'll be work either way. So we can definitely do it fully insured or self-insured.
Chair Gibbs.
That brings up a question, Christy. I know at one time prior to me joining the board, we were self-funded, and this board, or the board at that time, chose to move to Group Health Trust, which some will argue is a fully insured product, when I would make the argument it's a trust, and so it's a little bit different. And so what was the rationale, and I'm not sure if you know the answer to the question, as to what was the rationale that we moved from self-insured to Group Health Trust, and then well, I've got a follow-up question after that.
The county went out with I don't remember if it was an RFP or something, but we did not use your firm. We had used a different firm to do that. And with the combination of Group Health Trust and we were also still a member of the North Central Healthcare Alliance because the contracts came through them. We had the consultant do an estimate, and the cost savings at that time would be more to go with Group Health Trust than they are today. That structure is not what we have today, but it doesn't mean that the evaluation shouldn't be done. But that is why that structure at that time, there was an estimated cost savings for the county.
Then the other thing becomes, one of the challenges that we have historically faced is the challenges of recruitment in employees, and I think this board or this committee actually, said that we were not going to undertake a healthcare product that is going to lessen the value to our employees. Can you help me understand what the impact would be on the employees going self-insured versus currently the choices that the employees have currently? If we're going to be limiting choices to be able to save money, are we actually providing the same kind of coverage?
So from a perspective of the plan itself, the county would have the ability to just port the current plan as it stands today and just have the third-party administrator administer it as it stands today. So we could do it with no changes if that's something that the county would want to do. The self-funded allows you the flexibility to do other things. So for instance, we talked about the MRI, incentivizing employees to utilize that. For instance, no cost if you went to Smart Scan for that. Those types of incentives. Rather than a reduction, it's more of an enhancement type of thing. But again, the county would not have to make any changes. A third-party administrator can administer it exactly how it is.
But then if we're going to do that, if we're going to have a third-party administrator, which we currently have through GHT, would there be any savings?
Well, there could, because of it being just Marathon County. So Marathon County's experience, we would look at.
But the risk is the opposite side. there's
a positive and a
there's a positive and
Correct.
negative, equal and opposite reaction. I mean,
Yep.
the fact is that GHT has 40,000 belly buttons, and so we're leveraging 40,000 lives risk versus reward.
Supervisor Hart.
Thank you. I think I have a question for the HR director. What is the current participation rate of the wellness program as it sits right now? Do we have a lot of employees that are utilizing it, or?
No,
Okay.
no. I think it's 40%.
Okay. Because that leads me to another point here, and I know we discussed this the last time we talked about self-insurance, is I'm trying to put this delicately, the generally unhealthy population that we have in central Wisconsin. This is a culture built on beer and cheese. So generally we are unhealthy, and I know that provides for a very robust healthcare system because there's a lot of unhealthy people. So I think that also has to be factored in when we talk about this, because we are shifting that risk onto us, and we are taking that risk that we will have employees that will be healthier and not and be preventative and not have high risk claims against us. So I think we need to consider that when making this decision, especially if we have a low, under 50% utilization rate of our wellness program. That doesn't help it at all. Thank you.
Would you say that the low wellness participation could be improved if given the right incentives? Because that's been my experience, is that if you don't provide a great incentive, you're not going to get great participation. And I know that there's been studies that the cost and quality in healthcare are not related. So just because something costs more does not mean it's a better quality product. So Is it possible that we could increase that participation in our wellness programs if given the right incentives?
Yes, yes. So, I mean, depending on what that incentive is, obviously that'll drive the the percentage up. It's no different than decisions that we all make. If someone is offering you enough of a financial incentive, certainly you get to the point. And we do look at all of the clients that we work with as far as their wellness, and we can map out what the percentage increase depending on the amount of money based on historical. Yeah.
And then with this
Supervisor Hart.
insurance, do we have more control over that incentivization?
Yes.
Okay.
Chair Gibbs.
The one thing that I'm struggling with is when we look historically, and we look at even the trends that Price Waterhouse Cooper trends show, medical inflation 7%, 6%, 5.5%. And then we talk about Marathon County's historic numbers, 6%, 2%, negative 5% over that same period. And if we go to self-insured, and they're talking about the cost inflation factor in healthcare, wouldn't we just be without reducing the quality of healthcare plan and options that we have in our plan? Wouldn't we just be subjecting ourselves to the rate of inflation on our costs in our policy or in our plan if we're self-insured?
That's a component. Obviously, medical trend or medical inflation, you would pay that just like anyone else would, right? The combination of an independent primary care clinic with a health plan does provide a lot more opportunity to save money. And the reason I say that is because when it's independent, there is no incentive for them to refer to the system for specialty care, et cetera. So it's a different component, but it has to be thought of as part of the plan itself.
So I know we have a closed session item relative to a component of that delivery, but I think one of the issues is how do we move this issue forward? There was some discussion about trying to put together a work group or task force or others. We are in a short time frame. There are some issues that need to be addressed relative to capacity to design and reserves. There are issues relative to what would the design of that plan be from the perspective, and if we need to make a decision in July, we need to pull that group together and get going. Supervisor Marshall.
The employees sign up for the plan in, is it late October? If it's late October, why the long runway to between July and especially if we just port the plan over with a few enhancements that give incentive to use the lower cost providers?
It's more of a workday issue than it is an actual like doing just the flip of the switch. It's because of the new, yeah. But that's essentially what it is it's a workday issue. We're needing a longer runway to make sure that that work is done as far as the payroll system.
Chair Gibbs.
I'm a little concerned if we're going to have to make a decision by the July HR Finance Committee meeting. There's a lot of information I think this committee needs to take into consideration before doing that. So, I look at that and say, all right, let's have some, if we're going to have that information, maybe it is not the time to be looking at moving to a self-funded plan by July 1, but if we're going to implement something, it may be looking at giving us a better lead time and more information. I guarantee, well, the one thing I understand is there's a lot of information that, in my opinion, I need to understand the pros and cons, the risks, the rewards, the amount of employee upset that we potentially going to have, the amount of staff that's going to be needed to be put in place, and the number of contracts that are going to have to be put in place. Also, PBMs, you name it, and clearing agents. And I understand the need to start early to have a January 1, 2025 start date, but I think we've also seen the implementation of Workday and how that created some additional challenges just to get some of that stuff in place. So I'm a little concerned about having to try to make a decision in July.
Supervisor Lemmer.
Thank you, Mr. Chair. I agree with that. I think I have been on the recipient end of when my employer changed insurance, and it's itchy. and if it's done too quickly, it can build mistrust and just have the appearance of not being very transparent. I think the onboarding or education beforehand with employees is super important. Maybe even bringing their voices, especially if there's union employees, to the table so it doesn't feel so itchy.
I just would like to interject. I know that in the past, former Supervisor Fisher worked closely with administration relative to healthcare design, and I think the decision was made to stay with where we're at, but I think there was a desire to evaluate the concept of self-funding in the future. And what we tend to do is we tend to deal with this when we've got a relatively short window of time in which to evaluate it. I guess the options as I see them are we could look at it from the context of 2025, or we could look at it in the context of on a long-term basis, where is the county going and what steps would need to be addressed to give us more lead time? And are there components relative to our current contract with GHT that might be open for negotiation? Is there an opportunity to have preferential providers and incentivizing that in a way to save some dollars? Personally, I followed healthcare. I chaired the Assembly Committee on Health in the state legislature in the 80s, and at that time our capital expenditures were controlled. We had a rate review commission, and Wisconsin rates were very competitive. We've done a turnaround on those in a deregulated environment, and I'm very concerned about given the financial health of some of the providers and what that might do. If you can only negotiate prices down if there's somebody to negotiate against and with, and I think those are concerns that we ought to have going forward and begs for some study. But the question that we don't have to make the decision today, but we do probably at the next meeting is what is our path forward and what is the timeline associated with that pathway and what are people comfortable and how do we go about approaching it? And I think we've got some experts in the room, but there are a large number of issues that need to be resolved and discussed and thought through, and we had in the past done some of that. Started the discussion, but never completed it. So maybe perhaps for the next meeting we can have the discussion on do we advance a evaluation of that and what is the time frame for that? What are your thoughts on that approach? Chair Gibbs and
Thank you. I think the time frame, I think we need to do evaluation, but we need to do it with all the information. I mean, we only have to look to what happened in the Eau Claire region as far as healthcare and what that did to that system and the vacuum that created and potential costs. I don't even know what the impacts are on the cost of the system over there. But again, I just for me, I need more information, need to be studied out. And we need to, if we're going to be the policy board that we are, the policy of whether we move, granted, implementation is left up to administration. But we need to know all of the impacts, the pluses, the minuses, the risks, the rewards, and how that impacts employees, and as some people have mentioned, at least have the employees weigh in a little bit on their preferences. So I would be one to look for additional information and have a study group to study that out.
Supervisor Marshall. Okay. All right. So we can put it on the agenda for the next meeting. I'll work with administration relative to outlining what the issues might be and the time, we can give you the option of the time frame. And, is there a way to compartmentalize some of these decisions to realize some savings? But we can bring that back at the next meeting. I'm seeing a thumbs up from Administrator Leonard and shaking of heads, so we will do that. And those meetings always come quicker than we think. Thank you. I think I would prefer that we delay the closed session until, you want to take it up now? All right. We will take up the closed session now. So I would need a motion to go into closed session. If somebody could read the motion. Chair Gibbs?
Make a motion to go into closed session, roll call vote required pursuant to Wisconsin State Statutes 19.85, Parent 1, Parent E, and Parent G for the purpose of conducting other specific public business whenever competitive or bargaining reasons require a closed session, and for the purposes of conferring with legal counsel for the governmental body who is rendering oral or written advice concerning strategy to be adopted by this body with respect to litigation in which it is or is likely to become involved, to wit, a discussion of health clinic contract options and the impact of the clinic options on future employee health plans.
Is there a second? Any discussion? If not, Supervisor Lemmer made the second. We will, clerk, call the roll.
Robinson.
Aye.
Marshall. Gibbs. Hart. Lemmer. Poole. Reynolds.
And
Thank you.
Eric, you're going to stay as part of this discussion, and then we would ask the Finance Director and Human Resources Director and Corporation Counsel and Administration to stay. So if you could turn off your